Welcome back, everybody. Let's talk about something that will be relatively straightforward, lateral ligament reconstruction. The surgeries themselves are a little bit complicated, but it's not something you need to worry about too much, seeing as most of these patients that you're going to see are actually going to be non-operative. So these are basically your patients who have reported some significant ankle sprain or even unsignificant ankle sprain. I think a lot of doctors are referring patients with histories of chronic ankle sprains. And we actually have a clinical practice guideline related to ankle sprain, and the vast majority of probably any type of orthopedic injury could be related to an ankle sprain. I think we can all probably say in our history we've had at least one ankle sprain. And so it's very rare that the surgery is actually done. But we will talk a little bit about the surgery and what we do post-operatively. And we'll spend a little bit of time talking about non-operative treatment, but we're not going to spend a whole lot of time on either one. Ankle sprains are really part of a different kind of class, so that's something we're just going to touch on today. But we also want to touch on anatomy, so let's kind of remind ourselves about all of those ligaments that can be affected when we sprain our ankle. So ankle sprains tend to happen along the lateral side of the ankle, although sometimes it can happen along the medial side of the ankle as well. And the primary ligaments that we think about that get sprained are the anterior tibiofibular ligament and the anterior talofibular ligament, as well as on the lateral side, the calcaneofibular ligament. So those are the main ligaments that we tend to injure, but we also might be injuring the posterior tibiofibular and the posterior talofibular ligaments. So it's rare, but it does happen. And then on the medial aspect of the ankle, we have the deltoid ligament, which can also be involved with these bad ligament sprains. So when we think about how it happens, again, I think most of you probably have had this happen to you. So even if you haven't seen a lot of patients with ankle sprains, you remember the injury itself. And so oftentimes what happens is we have a plantar flexion and inversion moment at the same time. And so we end up injuring the anterior talofibular ligament. We also can have what we call a high ankle sprain, where there's a little bit more rotation at the distal tibulofibular joint. And so that's going to, patients are going to report a little bit more of an irritability a little bit higher than just the lateral, kind of the lateral malleolus. And so we're not going to spend a lot of time talking about that here, but just recognize that if they're demonstrating symptoms a little higher, it's not really affecting the same area. And so it's more related to that that tib-fib joint. We grade any type of sprain pretty much the same way. So where a grade 1 is a stretch, maybe slight tear in the ligament, whereas a grade 2 is a partial tear, and it's a pretty much complete, not a complete tear, but a partial tear that's very obvious on imaging. And then a grade 3 is where the ligament is completely torn through. And so you'll hear those grades often with ligament sprains. Since again, as I said earlier, sport-related injury, 10 to 15% of those sport-related injuries are ankle sprains. Very, very, very common. Unfortunately, chronic ankle sprains seem like they become more and more common every year, especially if you're working with relatively active people. 85% of those sprains are going to involve the lateral structures, like we said, with the anterior talofibular ligament being the most affected, followed by the calcaneal ligament, and then the anterior inferior tibiofibular ligament. And it's usually also something that can affect the peroneal muscles. And so if those peroneal muscles are weak or are not able to control the ankle, then sometimes we get injury to the peroneal muscles. And then, as I said earlier, if it's a bad enough sprain, we actually also end up with injury to the deltoid ligament, which is on the medial aspect of the ankle, closer to the medial malleolus. So, diagnosis, something you definitely want to think about, and this is kind of referenced here in this, this figure, is the idea that dorsiflexion and lack of dorsiflexion oftentimes is related to ankle sprains and chronic ankle sprains. So it's not a predictor of ankle instability, but it's very, very, very common that you're going to have decreased dorsiflexion. And so it's one of the big things that we need to think about as we're treating these patients non-operatively, pre-operatively, post-operatively, is really focusing on dorsiflexion. So as I said earlier, we do have an ankle sprain guideline. This guideline was originally published in the Journal of Orthopedic and Sports Physical Therapy in 2013, and you can see that we do have a version that's part of the Chinese Journal of Sports Medicine, translated into Chinese back in 2015. So I would highly recommend, if you're seeing a lot of these patients, that you refer back to our ankle sprain guideline. There was also a revision done that follows a lot of the same stuff. So non-operative rehab is pretty much what you're going to be doing with most of these people. There's not enough evidence to show that surgery is more helpful than conservative treatment. And so again, I would say most surgeons, even in China, most surgeons are not doing surgery. They're actually choosing to do non-operative treatment. And so they're sending them to you guys. And if it's a bad enough sprain, grade 2 or 3, then you're much more likely to have them be immobilized for a period of time. And you're going to see that splinting with these patients is actually a good piece of treatment. We don't talk about splinting being positive very often. You'll see when we talk about ACL in the next presentation that splinting is not necessarily recommended. But when it comes to ankle instability and history of ankle sprains and trying to allow a ligament to heal, we definitely will recommend splinting pretty regularly, as well as immobilization. So immobilization being immediate, like don't move it at all, whereas a splint, they might be able to take it off and do some range of motion. We do want them to start doing early mobilization, so just start weight bearing after several days, but using some sort of external support. So again, some sort of brace that helps to stabilize the ankle. Those lateral ligaments tend to heal really pretty well, and I've seen so many different kinds of healing processes. I mean, all the ligament healing is the same. It's the same timeline that we've talked about over and over and over again. And with a sprain, that means that at about 6 weeks, if it's a grade 2 sprain, even a grade 3, that they're pretty much healed for the most part. But what we don't understand as well is this idea of what happens to the mechanoreceptors and the nerve fibers following these injuries. And so we know that the ankle, a huge amount of what the ankle does is help control the rest of the body during weight bearing. And so we need to have good proprioception and good ability of our mechanoreceptors to know where we are in space, to know what we're stepping on, all those kinds of things. And so it's unclear really how well those things heal following significant ligament injuries. So we just have to spend a lot of our time performing rehabilitation that allows for us to really focus on proprioception and control. And again, I'm not going to go into a whole lot of detail about the non-operative treatment because you have a guideline you can refer to and other classes that you can go to. But I do want to talk about when surgery is actually indicated. Basically, we try conservative treatment first, and we try that for pretty much everybody. If conservative treatment is not helpful, or there's significant mechanical instability, meaning they can't even weight bear, so you can see with these athletes, some of them, it's a very, very significant sprain, then they may choose to do surgery. Most of the time, again, it's more of a high velocity type of injury where they didn't land correctly. So those are the ones that tend to have significant tissue damage and are going to require surgery. Whereas the ones like you and I probably who just step wrong or stumble during kind of basic running activities, we're less likely to require surgery and we're more likely to have conservative treatment. Again, what another kind of thing that surgeons look for considering surgery is this idea of having medial ankle instability. And so that deltoid ligament, as well as cartilage along the medial aspect of the ankle, can become irritated if it's a very bad injury. And so we have to really think about possibly doing surgery to help control and repair the lateral side of the ankle so that the medial side doesn't have to work so hard. So that's another reason that a surgeon may choose to do surgery. Another thing just to kind of bring up that I think is important for you to understand is that the types of movements that cause ankle sprains when we're young cause ankle fractures when we're older. So we're not going to talk about fractures until module 4, but just keep in mind that as we get older, we talked about the fact that our ligaments become less flexible. So they actually don't have that same stress-strain curve that we talked about with the ligament lecture. And so as we get older, the ligament doesn't stretch the same way, and so therefore doesn't usually tear the same way. And instead, we end up with fractures. Whereas when we're younger and we have much more flexible ligaments, that same movement or instability will actually lead to a ligament tear, sprain. And again, if it's bad enough, then we're going to do surgery. So I don't want to go into a lot of detail about these surgeries. The gold standard for a lateral ligament surgery is what's called the modified Brunstrom procedure. And basically what it is they just come in and they repair it. So they recognize that there's a tear kind of in the middle of the ligament itself, and so they just pull it together and tie it up. They may end up coming in and using other ligaments like the lateral calcaneal ligament or the calcaneal-fibular ligament, and actually use that to help stabilize it a little bit better. What they've found is that it's not as successful of a surgery if their patients are overweight, or if there's significant amount of laxity or they've had other surgeries before. But basically this idea is they just kind of shorten the ligament itself, whatever ligament it is. They may use something else to reinforce it, or they might just stitch it up. And that's the most common surgery that you'll see. But there are other surgeries, such as the Evans, which actually limit ankle inversion. So it just kind of like totally tightens up all of the tissue on the outside of the ankle so that you don't get subtalar motion into inversion. There's also what's called the Christman-Snook procedure, which is an allograft, and then there's the Watson-Jones, which is also an allograft. So the picture here is showing allograft. With the anterior talofibular and the calcaneal fibular ligament, they basically are inserting a graft, and the graft is actually superficial to the fibular tendon. So it goes on the outside rather than on the inside. And the idea is that it's less likely to have the graft to wear down, but it tightens up the joint a lot. And so you end up with a much more stiff ankle. Again, very similar to the Evans procedure in that it doesn't allow for a lot of inversion. And then the other option, this Watson-Jones, actually uses the semitendinosus tendon and reconstructs the ligament using a tendon. So kind of similar to maybe what you would see with an ACL graft. So those are kind of different options that you may see. And I think the most important thing to keep in mind is if they are doing an allograft of some kind, then there is tissue that has been taken from somewhere else in the body, either ligament or tendon. And so you need to consider how you rehab those tissues as well as the area that's had the surgery. Complications. These patients, oftentimes, if it was a really bad injury, or possibly a lot of chronic ankle instability, they're going to end up reporting more instability, and this idea of the ankle giving way 6 to 11 years after treatment. So again, at least a third of them basically report that the surgery did not do what it was supposed to do. And so you might be seeing these patients 15 years later with ankle instability following the surgery, and so you're going to work with them pretty much like you would with one of your non-operative conservative patients. Preoperatively, if you do get to see them, you're basically giving them some sort of brace. You're making sure that they are stable and not highly irritable during the period before surgery. And then you're also making sure that hip and quads and hamstring and all that stuff are nice and strong going into the surgery. So following surgery, the first phase usually lasts for about 4 weeks. And this phase is that protect in motion phase where we're going to be protecting the surgical site. We want to make sure they don't have DVTs. We're managing the edema. So all of the things that we talked about before. These patients will start off non-weight bearing. And so you need to make sure they understand their weight bearing precautions. And you should also be instructing them on how to do ADLs non-weight bearing. So that's a big part of the first week or so of treatment. We also really want them, and you'll hear this a lot with a lot of our other patients, is that we want them to keep up some sort of cardiovascular activity. So depending on if it was a cervical issue, a lumbar issue, a shoulder issue, we're getting them walking very quickly. With these people, we're not walking, but we're probably doing something like an arm bike, something where they can actually get their heart rate up. So patient education during the first phase is basically non-weight bearing, no range of motion unless the surgeon has said it's okay. And they're basically just in a brace or in a cast. Non-weight bearing is usually for 1 week, and then we get to touchdown weight bearing in that brace, cast, or boot after a week, and then partial weight bearing at about week 4. Okay, so it's a slow weight bearing process after the surgery. Again, it's a ligament, so we need to be kind of careful. And it's a ligament that obviously will be strained with any weight bearing. So most of the time they're wearing some sort of brace or cast for at least about 5 weeks. And that's going to allow for us to increase weight bearing as we go into the second phase. But our primary treatment is teaching them how to perform activities with non-weight bearing. And that's a challenge. And usually you just have to see them maybe once or twice during this phase. Because again, we're not doing range of motion, we're not doing manual therapy, except maybe some edema massage type things that we can do with their foot elevated and above the brace or cast, unless it's a removable brace or cast. But we really do want to help them try to find ways to stay conditioned cardiovascularly during this period. So I kind of mentioned the whole idea of a fracture being one possible injury and the sprain or strain being the other. And so after fracture, there's going to be a certain rehab protocol, and after ligament reconstruction, there's a rehab protocol. Basically after a fracture, we're going to be non-weight bearing for a longer period of time. So weight bearing goes slower. We're usually non-weight bearing for at least 4 weeks, and then full weight bearing at week 9. Whereas with a ankle reconstruction, we're going to start weight bearing after usually 1 week, and then we're into full weight bearing in a cast at 5 to 6 weeks. However, we do work on range of motion much earlier with ankle fractures. So we're hoping that the patient who's had a fracture has some sort of removable cast so that we can start doing range of motion at about 2 weeks. Or if they're not, when they get that cast off, we can start doing range of motion immediately. Whereas with ankle ligament reconstruction, we're not starting active range of motion until about week 4 or the second phase. And that's just dorsiflexion and plantar flexion. We are not doing inversion or eversion until the 6th week. Okay, so for those, we're going a lot slower with range of motion, but faster with weight bearing. So phase 2, week 4 to 6. And this is where we would like to start working on dorsiflexion and plantar flexion, and dorsiflexion to 0 degrees is our goal by the end of 6 weeks. We also want to be into full weight bearing, but likely with a boot of some kind. We want to start doing things like neuromuscular control during this period and really helping to progress their ability to weight bear. So patient education, continue to use ice, elevation, compression, all the things for pain control. But again, we're wanting to spend a lot of our time on doing normal functional movements into full weight bearing with the cast. So we can start isometric exercises during this period. So that's how we can get our inversion and eversion muscles to turn on, is with isometrics. We also can start doing passive and active range of motion, plantar flexion, dorsiflexion, and really spend a lot of time working on the hip and the knee while watching our weight-bearing restrictions. So again, we're continuing to use some sort of bracing during this period, and we are playing with weight-bearing and increasing weight-bearing. Repeating myself, I feel like, but that's okay. You can certainly use modality, soft tissue mobilization to help with swelling. Remember, the ankle foot is the furthest joint away from the heart, and so helping patients understand that they could have swelling for up to a year following this type of surgery is usually a very helpful bit of information, so that they're not worried about all the swelling that they're seeing around their ankle. It's very, very normal to have that at this point. So phase 3 is week 6 to 10. And at this point, the patient should feel comfortable with how they're managing their edema and their pain. That doesn't mean they won't have edema. We're hoping that their pain is significantly decreased by week 7. And we also want full active and passive range of motion of the ankle. With our strength, by the end of this phase, which you see is week 10, so by less than 3 months, they should have pretty much normal strength, which is asking a lot. I would say 3 months is probably a little bit more fair, but it's doable. We also need to think about proprioception and balance during this phase, and then really try to decrease their gait problems. So we're making sure that their range of motion is good enough that they can get dorsiflexion during gait, which is probably the biggest issue. And making sure they're not so stiff that they don't get some sort of subtalar joint control and midfoot control during gait. So we want to start weaning them off of the big boot and into more of a stabilizing brace or orthoses during this period. And so finding the best thing that they're comfortable in but still provides some ankle support is kind of what your goal is. Continuing with those isometric exercises, but we're also doing lots of active range of motion. We can start doing bilateral heel raises, squats, lunges, things like that. We can also start doing more biking, treadmill. If they can have access to a pool, I love being able to do pool therapy during the earlier phases of rehab. And then proprioceptive exercises, lots and lots of balance. So here's just some pictures of some different suggestions on how this can be done during this 3rd phase. Yes, you can start doing things like a single leg squat. You can start playing with balance on uneven surfaces. All of those things are appropriate. You also might be doing some joint mobilization at this phase. I really wouldn't recommend that you're doing it before this phase, just because you want to allow those ligaments to heal. But during this 3rd phase, you may need to be doing talocrural joint mobilization. You may need to do some subtalar joint mobilization very, very gently. Remember, we talked about ligament healing time, and it's about 12 weeks really that we can start stretching against the ligament. So you have to be a little bit careful with doing that in this phase. So I'd say you spend more time working more dorsiflexion, maybe even midfoot if you need to, and waiting on the subtalar joint till after about 12 weeks. But we can start doing sport-specific training. So phase 4 starts at about week 11. And I would say week 12 might be a little bit more normal. But our goals during this phase is that we really want them to be able to start returning to their sports. So really starting to help prepare them for running and cutting and jumping. And the idea is obviously we're discharging them to a program that they can do on their own during this phase. But doing, start balance and these more advanced balance and jumping activities. Most of these things, though, are going to be done with a brace. So keep that in mind if you look at the guidelines, like I mentioned at the very beginning. Most of the time, we're still recommending using a brace for sporting activities. So we're hoping that during their normal day-to-day life, they don't feel like they need it, that they feel stable enough. If they're just walking on even surfaces and doing stairs and things. But when they're getting back to sport, using a brace during this healing process is absolutely normal. and we want them to feel comfortable in the brace so they can use it. We're also going to start doing a lot more pivoting, cutting, and these more advanced type of exercises that hopefully we can do lab, so we can kind of talk about what these look like when we're in lab, so that you can have some better ideas of how to get these guys to return to sport. So there's references. I said this one would be pretty quick. It is pretty quick because, again, it's just not very common. You're not going to see it very often. You're much, much more likely to work with these people non-operatively. So you might have more time in lab to talk about that stuff, but just keep in mind that this is just something you'll have to just go back and reference maybe periodically when you do see these patients, because it's going to be pretty rare that you do.